Over the past 45 years, we at JB have been known for our solid foundations, unique approaches, and an unwavering commitment to healthcare. Globally, we have been a symbol of trust and reliability. 4,000 plus employees, 40 plus global markets, 20 plus therapeutic categories, 7 world-class manufacturing facilities, 2 global subsidiaries, are all united with the mission of spreading good health globally. Today, we feature amongst the top 25 pharmaceutical companies in India, with 5 brands ranking amongst India's top 300 pharmaceutical brands. Indeed, generations of people have got well with our medicines. We make the highest quality drugs available across over 600,000 pharmacies of India, literally in every pin code. Now, we are evolving and becoming more agile, lean and simple. Our offerings and capabilities are becoming more diverse. Our processes are becoming more robust and lean. Our 7 world-class manufacturing facilities in India have global accreditations and unique technologies. Our consistent good quality medicines and compliance across global markets has made us a trusted partner of choice for leading global MNCs, manufacturing generic products as well as branded formulations. A feather in our cap is our lozenges business, and we are one of the world's top 5 manufacturers of medicated and herbal lozenges. Our lozenges come in a myriad of flavors, shapes and forms, so that our customers get exactly what they want. Our progressive vision for global healthcare made us explore international.
Yeah.
Yes.
Yeah.
Perfect.
You give the countdown or
Yes, ma'am. So within a 10 seconds, we will allow to the attendance.
yes.
So, ma'am, it's 3, 2, 1. Over to you, ma'am. Now you can start the session. We are allowed to the attendance.
So good evening to all. I am Dr. Komal Mandgaonkar on behalf of JB Pharma. I welcome you all for the tonight Lead HF program, the highlights on the Best of ACC Congress and the topic on choosing the right attorney. It's a privilege that we have all the national experts today here who are going to share their experts insights on this very important 2 topics in cardiology. Our esteemed moderator for tonight's meet, we have Dr. Pramod Kumar Kuchilkanti sir. Sir is a senior interventional cardiologist from Yashoda Hospitals, Hyderabad. Our esteemed speakers for tonight's meeting, we have Dr. Kamal Sharma sir, a senior interventional cardiologist from Ahmedabad. He is going to present on Best of ACC Congress 2025 highlights. On a second speaker, we have Dr. Rajat Sharma sir, a very senior cardiac electrophysiologist, Heart Rhythm Services, Fortis Hospital, Moholi. He will going to talk on the important topic of choosing the right attorney in heart failure. Followed by, there is a panel discussions. We have experts panelists here, Dr. Sayojita Chakrabarti sir, senior interventional cardiologist, cardiac devices specialist, Kolkata, Dr. Mahentesh Charnimat sir, from the Tathagat Heart Care Center and Hospital, Bangalore, and Dr. Vijayant Devendraj sir from the Max Super Specialty Hospital, Lucknow. I welcome all the experts in the cardiology tonight for this meeting. And with this, now I request our esteemed moderator, Dr. Pramod Kumar sir, to set the context for the meeting. Sir, please.
Yeah. Thank you, Komal and JB Pharma for bringing us together on this day for discussion on some interesting topics, especially the ACC, which was conducted in March in Chicago. There were more than 50 cases that were, the late breakers that were presented. And some of the interesting things will be picked up, and Dr. Kamal Sharma is going to run through all those latest advancements that happened in various fields. It includes not only heart failure, but also there are some things on the post-AV heart failure with dapagliflozin, and also the latest sensation that's happening across the country, that is Monjaro, tirzepatide. That is also one of the topics he is going to address. And after that, some of the ACC guidelines about the STEMI and NSTEMI is also included. I think it's a potpourri of a lot of interesting topics that Dr. Kamal is going to address. And after that, we will have a discussion on choosing the right ARNI by Dr. Raja Sharma. There is a paper published recently which compared one of the brands, that is Asmada, with other 16 brands, and what are the important technological considerations in the structure of this molecule and how this is going to impact the stability and how it is going to benefit the patients at large. I think that is one of the important things we have to consider when we prescribe a drug. Dr. Rajat is going to talk about that. And we have expert panelists who are going to be there with us to initiate discussion and also answer some of the questions that are going to arise. And I think without much ado, I hand over the podium to Komal, and then Kamal to start his presentation.
Shall I
Yes,
start, Dr.
yes,
Komal?
yes,
Yeah.
please start.
All right. So good evening, everyone. Thank you very much for kind words and looking forward to this session. Best of ACC Congress. It's good that we do this with JB for now a couple of years. Good advantage of this is that the science reaches through the technology to us in this modern era very rapidly, and we all can absorb what has been late breaking at the ACC. So, as was already mentioned, this year ACC had 50 plus late breaking trials. Experts provided insight into groundbreaking advances, and it featured a record number this time, actually, with the technological advances, which included the expert discussions on ARNI in heart failure, inclisiran in lipids, LDL lowering therapy. Guidelines have changed. ACS definition, something was being added, so we'll look into that as well. Lipoprotein small a testing, right now the therapies are being evaluated, but lipoprotein testing itself has been showing some promising results. Ezetimibe adjunct therapy, clopidogrel aspirin, high-risk PCI, tirzepatide in heart failure, and long-term outcomes of PCI versus CABG. So that's the complete data sets that we are going to look at, complete set of 10 topics in 15 minutes. I'll try to run through as quickly as I can without wasting any lack of knowledge, and excuse me if I take a couple of minutes more than the allotted time. So the first one is going to be about taking congestion out of heart failure. Remember, this time there was one more trial which looked at into water restriction, and it showed that you need not ask the patients to restrict water in heart failure. And we are looking to, however, look at the impact of ARNI and SGLT2 in loop diuretic reduction and the cardiac function. Then ARNI in hemodynamically stabilized patients after acute heart failure. We'll have a look at a systemic review and meta-analysis, structural abnormality, and effects of ARNI in patients with mildly reduced or preserved ejection fraction, which is the Paraglide HF trial, big trial that came out. So these three trials are primarily going to be on the topic that we are going to be importantly discussing with Dr. Rajat, taking up on why the original ARNI makes a big difference. DAPA-TAVI, another trial where DAPA in patients undergoing TAVI was looked at. Comparative safety, efficacy, long-term injectable cholesterol lowering network analysis of alirocumab, evolocumab, inclisiran, and mipomersen. Impact of adherence of LDL lowering therapies on cardiovascular outcomes among adults with atherosclerotic CVD, heterozygous familial hypercholesterolemia, and primary hyperlipidemia. We look at the 3-year outcomes of ezetimibe as an adjunct to the statin therapy in coronary artery disease, talking about the new ACS guidelines, and lipolytic testing and its impact as tirzepatide in heart failure with preserved ejection fraction, and CKD in Summit trial. And then we also look at PCI rebounds at 5-year, mostly matched CABG FAME3 data sets. So this is the complete basket, actually 10 trials and 1 guidelines, as I mentioned. The first one was to look at the congestion out of heart failure. Basically, this was to evaluate effect of ARNI and ARNI plus SGLT2 on loop diuretic dose adjustment in heart failure, and to look at the echocardiographic parameters as they change over 1 year. So this included patients of heart failure on maintenance loop diuretics. They were treated either with ARNI alone or ARNI with SGLT2. And we all know this, we have practiced in our practice itself, that when we add SGLT2, we actually reduce the dose of diuretics. This is the science of the same logic that we have often practiced. it shows that the 42% of patients they discontinued diuretics in both arms. 20 to 22% of patients reduced their diuretic dose with no significant difference between the two groups. So a lot of importance here is that maybe the ARNI itself may suffice for need or no need of diuretics rather than SGLT2 added because there was no significant difference between the two arms. However, echocardiographically looking, the reduced RA pressure, reduced pulmonary artery pressure, reduced LA volumes were documented, all statistically significant. Both had improved ejection fraction as compared to the control arm. The additional importance of adding an SGLT2 was reduced diastolic LV internal diameter, which was reduced significantly. So barring that, other three parameters were managed by ARNI alone. It's only reduced diastolic LV internal dimension that improved with when you added SGLT2 to ARNI. And of course, both of them improve ejection fraction across the subgroup of the patients. So this is the discontinuation rate. If you look at diuretics, 42.8 versus 42.2, no difference. Decreased almost 22 and 19, increased very little and no change in 20% versus 24%. And the EF, as you can see, was improved in both the groups by almost 6 to 10%. So additional 4% improvement in EF from 35 to 45 compared to 6% improvement from 33 to 39. And both were statistically significant. RA pressure, mean PA pressure were more significant in ARNI group, and end diastolics was more important in patients with combination. LAVI was improved in both, more with the ARNI, not so much with the SGLT2. There was a trend, however, towards it. So ARNI-based therapy alone or with SGLT2 increased loop diuretic dependence while improving cardiac filling pressure and function. And it suggests ARNI may help in decreasing the diuretic burden in heart failure itself. The next one is about the hemodynamically stabilized acute heart failure systemic review meta-analysis of ARNI usage. So these were acute heart failure patients. They were to be compared with ACE or ARB in stabilized acute heart failure. NT-proBNP, worsening kidney function, and hyperkalemia were the primary outcomes. They randomized the patients to either of the two groups, which is either ARNI or versus ACE or ARB. Mean difference and odds ratio with 95% confidence interval was looked at, and random effects of model for pooled estimates were looked into. So 3 RCTs comprising 1,723 patients, of which nearly 50% were on ARNI. NT-proBNP reduction at 8 weeks was significantly lowered by 22% with ARNI. Worsening renal significance or hyperkalemia was no different between the two groups. So these are the 3 trials: Paraglide HF, Pioneer HF, and Premier trial. And all of the 3 had nearly same weightage in the forest plot. No significant difference between the groups in worsening renal function. Paraglide showed some benefit towards sacubitril/valsartan. However, the pooled analysis had no benefit. So sacubitril/valsartan reduces NT-proBNP and finding support its usage initiation to be safe and effective in acutely decompensated patients who are hemodynamically stabilized after the acute episode. The third trial of ARNI was in patients with mildly reduced or preserved ejection fraction and worsening heart failure, the Paraglide trial. Now, the Paraglide trial basically looked at the structural abnormality, including LVH, LA appendage enlargement, efficacy of ARNI in patients with EF more than 40%, worsening heart failure, and they looked at the NT-proBNP reduction across the different subgroups in the structural abnormality in Paraglide subgroup of patients. So Paraglide heart failure, we categorize in the 3 groups based on echocardiography, whether the patient had either LVH or LAE, had both LVH, LAE, or none. So time average proportion change to NT-proBNP was looked at from 4 to 8 weeks that were analyzed. An ANCOVA model was used to treat treatment by degree of structural abnormality interaction. 97% plus had echocardiographic data of LVH and LAE. 57%, 34.5% had both, 39.2 had either, while 26.2 had neither. So sacubitril/valsartan led to great numerical reduction in NT-proBNP as compared to valsartan, and the win ratio, which was used here by ANCOVA method, it significantly favored sacubitril/valsartan in those with LVH and left atrial enlargement. So more the structural abnormality, more is the improvement in the outcomes as measured by NT-proBNP. So this is the trial plot of the P interaction, the not significant difference between the 3 subgroups. However, it was most evident in the both LVH as well LAE being present. The ratio of change was 0.78. So it is consistently reducing NT-proBNP in patients with EF more than 40 and worsening heart failure. And the trend is greater with those who have both LVH and left atrial enlargement. So it is effective across the subgroup. Coming to DAPA in TAVI subgroup, this is a very important trial, which was mentioned by the moderator. So to assess the effectiveness of DAPA in reducing death and heart failure worsening after TAVI in high-risk patients with aortic stenosis, a randomized trial in Spain underwent TAVI, had heart failure plus diabetes, renal insufficiency, or LV dysfunction. 10 milligrams plus standard of care DAPA was compared with, and death from any cause or worsening at 1 year was compared with the outcome. Primary outcome, death or worsening heart failure, was lower with DAPA 15% versus 20%, which is 28% relative risk reduction. Worsening heart failure occurred less frequently with DAPA and 37% relative risk reduction, and death also was reduced by 13%, though this was not statistically significant. But the study was not powered for death alone. It was powered to look at combined endpoint, just like DAPA-HF. And again, it showed that the patients who were older with aortic stenosis undergoing TAVI at high risk for heart failure, DAPA resulted in lower incidence of death from any cause of worsening of heart failure. So that's DAPA-TAVI trial. The next one was about injectable cholesterol-lowering agents, network meta-analysis. All the injectables that are available have been evaluated in this trial. They looked at the safety efficacy of the PCSK-based therapies in lowering LDL-C and reducing event rates. The role as an adjunct to statin therapy in those who do not achieve LDL goals or are statin intolerant was also looked at. So they found out nearly 2 lakh patients, 1,98,041 to be precise, in 57 studies. Multiple databases were searched. Risk bias was assessed using ROB2 network. Meta-analysis with Strata 18. So inclisiran showed mean LDL reduction of 47 compared to placebo. Supra ranking position inclisiran on top. We all know the efficacy now. There is no controversy about it. It's the most efficacious therapy amongst the 4 lot. Top 3 LDL lowering agents with evolocumab and alirocumab following the inclisiran. Inclisiran has modest impact on CV outcomes compared to PCSK9. I think the only reason that its dedicated Orion series of dedicated trials are on the pipeline. By the year end or next, when we get those data sets, probably inclisiran, it's anyway cheaper in the long run compared to evolocumab. Alirocumab is going to come and position itself as the robust, the so-called lipid vaccine. Inclisiran has a modest impact on outcomes, and it's demonstrated favorable safety profile with very few side effects than the alirocumab or evolocumab for that matter. This is the data sets, and this is the fluorescence plot for the same. So inclisiran is effective agent, ranking high among PCSK9, offers significant reduction on LDL with safety profile. Its impact on cardiovascular remains modest. In the network analysis that they have done, real world evidence, as I mentioned, is still to come. Mipomorsen not so strong. Evolocumab, alirocumab, and inclisiran are the one that take the top lead position with between them. This is the Sucra analysis, the same, which is ranking these evolocumab stands first, followed by the other drugs. So adherence of LDL therapies in patients who have ASCVD, heterozygous familial and primary hyperlipidemia was the another trial where they looked at the inclisiran versus PCSK9 monoclonal antibodies to estimate the CV events prevented due to better adherence compared to monoclonal antibodies. And they looked at the adherence level and impact of LDL-C and CVOT outcomes in the heterozygous FH or primary FH. So this is a Komodo Health data sets that they've looked at in the US patients with ASCVD, heterozygous or primary hyperlipidemia initiated on inclisiran or PCSK9 monoclonal antibodies. The proportion of days recovered in more than 80%, inclisiran nearly 79%, PCSK monoclonal was 50%, 56%. CV event reduction was estimated using the cholesterol CTT statin trial meta-analysis over 5-period method. So the results were as not very surprising because of the twice yearly dosing. There is better adherence with inclisiran and 50% larger adherence adjusted to 12-month LDL reduction compared to monoclonal antibodies. Higher ASCVD event prevention because of the more adherence itself, more ASCVD events were prevented as compared to PCSK9 inhibitor. And that's between the 3 subgroups. You can see whether you look at the ASCVD, you look at the heterozygous, or you look at primary AFH, all the three subgroup, the adherence was better with inclisiran as compared to any of the monoclonal antibodies. Again, this is the diagram which has looked at the adherence plot. 12-month discontinuation rates almost double for the monoclonal antibodies, 19.8% versus 43.5%. No wastage, where 10% wastage was there with monoclonal antibodies. And key outputs, the average difference was again more significant. ASCVD, heterozygous FH or PH, all of them 34.8% change versus 23.3%. And hence the number of events prevented over 5 years, they are huge. ASCVD is 2,782 events, 3,422 and 3,146 respectively with inclisiran. Compare the number with PCSK monoclonal antibodies, nearly more than 3,000 patient difference that were benefited in 2 lakh patients who were followed up in this trial. So scenario analysis shows that the ACVD prevented at very high-risk population was 42% higher with inclisiran. When utilizing treatment-specific average adherence LDLC reduction, it was estimated at 41% with inclisiran versus only 32.5% with PCSK. And ASCVD events per into 1 lakh were projected to be 3,211 versus 2,600. As I mentioned, nearly 1,000 difference between 600 here and 1,000, nearly 700 difference in the FH or PH group. So higher adherence and more events, 28% more events prevented in US individuals over 5 years. 3-year outcome of adjunctive to statin in coronary artery disease of ezetimibe. This is ezetimibe long-term data in the CAD patients with impact of ezetimibe use, all-cause mortality and cardiovascular events at multinational data sets. They looked at the two groups, ezetimibe versus non-ezetimibe users, 3-year all-cause mortality, including acute MI, CV events, and acute heart failure were looked into. Propensity matching was done to balance the baseline characteristics, and patients on ezetimibe had 44.6% lower risk of 3-year all-cause mortality. So this is why most of our cardiologist friends across, including myself, have started giving our patients at the time of PCI high-dose statins along with ezetimibe. We, as in Indians, continue to be at higher risk. So ezetimibe statin reduced the risk of acute MI by 18%, CV events by 28%, and even surprisingly, acute heart failure by 26.4%, probably because of lesser myocardial infarction driving lesser events of heart failure. So this is the 3-year outcome of ezetimibe as adjunct to the statin therapy. Long-term ezetimibe with statin is associated with significant reduction. Coming to the new ACS guidelines, this was a rigorous evidence-based process aimed to refine the clinical recommendations in patient care. Over 14 months, an extreme elite panel looked at the strict conflict of interest management, conducted multiple rounds of peer review, and ensure the clinical relevance and accuracy. The refinements include revised definition of ACS, updated recommendations and antiplatelets, new guidance on pre-loading strategies and discharge antibiotics, revask techniques, recommendation for optimal patient outcome. Significant recommendations are this now class 1 recommendation for dual antiplatelet for 12 months, no shortcuts, no 3 months, no 4 months, no 6 months, 12 months DAPT. However, ticagrelor monotherapy is an option to reduce bleeding risk, and preference for radial access is
There
now
was ಸ್ವಲ್ಪ
endorsed.
ನಂದು audio problem ಇದೆ ಅನ್ಸುತ್ತೆ. I'm not able to hear it.
Am I audible?
Yes,
Not able
yes,
to hear.
yes. You're audible,
Dr.
sir.
Yes, you are audible.
Okay. So preference for radial access, encouragement of intra-coronary imaging was also recommended. Non-statin lipid lowering therapy for patients with ACS was recommended in the 2025 ACC-AHA ACS guideline recommend more aggressive lowering of for especially ACS patient, shift from only high-intensity statin to combination and non-statin lipid lowering agent, which include ezetimibe, evolocumab, alirocumab, inclisiran, or bempedoic acid. So the definition now is non-occlusive thrombus, ST depression or ST inversion, and now biomarker positive is called as NSTMI, biomarker negative would call as unstable angina. So non-occlusive thrombus is one definition that would present either as unstable or STMI, while occlusive thrombus is now categorized as what is called STMI. The class 1 recommendation for ACS maximally tolerated with LDL more than 70, you should add a non-statin lipid lowering. That's straight away class 1. So choose between PCSK9, ezetimibe, and bempedoic, but above 70, you must go on full throttle to add another therapy to lower it even further. In patients with ACS, concomitant initiation in combination of maximal tolerated may be considered to reduce MACE is 2B, and I'm sure this will change in coming years as we know the data sets becoming emerging for the same. ACS baseline lipids, you should send patients not on statin, low grade or high intensity. Initiate high dose statin, may consider concurrent adjunct ezetimibe. Patient already who reached the maximal tolerated dose, if it's less than 55, you can continue the same. Between 55 and 70, you should add non-statin LDL lowering therapy, and more than 70, add a non-statin again. So statin intolerant, of course, you can go with a non-statin LDL lowering therapies directly. Lipoprotein small a testing, the therapies to modify the same are already in pipeline. Some of the trials are ongoing, including a Novartis molecule we know of. Lipoprotein small a testing, however, itself can ASCVD event in real world. Whether its testing influences the treatment intensification was the idea of this trial. They looked at the retrospective analysis of US Medicare, commercial and Medicaid health plan data sets of last 5 years. And they measured the LDL, lipid lowering therapy initiation, intensification, discontinuation rate, LDL-C reduction, cardiovascular event risk of MI, revasc, or any ASCVD. Higher LLT initiation, greater LLT intensification, lower LLT discontinuation was found, and this patients who were getting a lipolitide tested, lower LDL-C also was achieved. So with the lipolitide tested, probably physicians tend to be more aggressive in treating. This translates into lower risk of MI, reduced revasc rates, and fewer ASCVD event rates. So testing was associated with better initiation intensification, lower LDLs achieved, and reduced event risk. Findings suggest lipolitide testing itself enhances the lipid management more aggressively. For the sake of time, I'll run quickly through Summit trial, which looked at the impact of CKD on clinical response to tirzepatide in patients with obesity-related HFpEF. They looked at the evaluate discrepancies between creatinine and cystatin C-based estimates of EGFR in response to tirzepatide, because it's believed to be modified by the same. So Summit trial, 731 patients, BMI of more than 30, enriched for CKD, tirzepatide versus placebo, 104 weeks of therapy. They looked at the KCCQ-CACS clinical summary score at 52 weeks, and he estimated the EGFR at 12, 24, and 52 weeks using creatinine and cystatin C-based estimation formula. So 60% of patients of HFpEF had BMI more than 30 had CKD. So the CKD is a big problem in patients with HFpEF with high BMI. Tirzepatide reduces cardiovascular death and worsening by 38%. So now we have data for this therapy for patients with HFpEF. Patients with CKD had 50% higher risk of worsening heart failure. EGFR measured by cystatin C was 9 lower as compared to those measured by creatinine. So tirzepatide improved EGFR at 52 weeks in all patients in CKD, and it causes initially a decline just like SGLT2 at 12 weeks, but it improved at 52 weeks. So this is the combo. If you look at the baseline cystatin C versus baseline at EGFR creatinine based, there is good correlation, but 9% difference between the two. Long-term tirzepatide therapy improves renal function. As I mentioned, EGFR estimation with obesity receiving creatine-based therapy may be influenced by fat and muscle mass. PCI rebounded 5 years, mostly matched CABG's final FAME3 data sets. So they looked at the 5-year outcome of FFR guided PCI versus CABG in patients with 3 vessel coronary artery disease, major. Look at the death, stroke, MI, and repeat revasc. FAME3 showed that 1,500 patients, 3 vessel disease, PCI FFR guided was done versus CABG was done, 5-year follow-up. And the syntax score was also looked at, based analysis was done. You can see that there is no significant difference in composite endpoint of death, stroke, or MI between the two groups at 5-year. Higher rates of MI repeat revasc in PCI group, and no later accrual benefits after 1 year for CABG. So again, CABG probably doing better off with PCI, which is guided by FAME 3 data sets kind of patients. Low syntax, high syntax, both groups, PCI and CABG, had comparable outcomes. So one positive take here. And intermediate syntax PCI showed worse outcome, however. So PCI outcomes improved significantly at 6% lower rate compared to 2009 syntax trial, but CABG outcomes remain consistent. So FFR guided PCI has improved significantly, now approaches CABG in long-term outcome, but CABG still continues to be superior with intermediate anatomy. Advances in stent, physiology guiding, and medical therapy have narrowed the gap, but still the shared decision would continue to be the therapy of choice in our patients. So thank you very much. I'm sorry for exceeding the time, but I felt that these were 10 important trials. Plus 11th, there was the ACS guidelines. So 11 topics to cover. At a regular plus slightly 1.5 times the speed, still would take some amount of time. Thank you very much.
Excellent, Dr. Kamal. You have covered very nicely all the topics and very crisp presentation. Congratulations for keeping to time. I think we will take the questions and initiate the discussion after the other talk. May I request now Dr. Rajat Sharma to share his slides and present his thoughts on choosing the right ARNI.
Yeah, thank you, Dr. Pramod and Dr. Kamal for the nice presentation. So the second topic is basically around the ARNI that has been proven to be a first-line therapy for a heart failure with a reduced ejection fraction and probably for the heart rate in the mid-range ejection fraction and preserved ejection fraction, and may not be the class 1 indication, but you do have some kind of effect in all the spectrums of the heart failure. So, having said that, when we are talking about a whole spectrum of the patient that we commonly encounter, that is the heart failure with a reduced ejection fraction. So, because of the huge population in India, like we have a very, very huge number of patients coming to us with the heart failure with a reduced ejection fraction. And as we all know, that each hospitalization because of an worsening heart failure or an acute decomposition of the heart failure, that eventually leads to an escalated mortality. So these are the kind of problem that we'll be facing time and again. And fortunately, this set of medication has actually shown some huge benefit in solving these problems of heart failure with a reduced ejection fraction, which was typically associated with the huge mortality and morbidity. In an Indian prospect, this the volume of the heart failure eventually is very high, but the typical problem here is we have people who are quite younger, and the malignant nature of the heart failure is quite bad as compared to the other parts, where the mortality and the morbidity, whether it is short-term mortality or the morbidity, is quite high. As we all are convinced about the recent guidelines by various ACC, AHA, or the ESC, we have a fundamental core pillar and the RCT, which is backing this data for this medication. That has been a very, very successful trials from all the medication, and it has shown some significant mortality and the morbidity benefit. So as for today, we have this whole line of therapy, and when the patients start declining, we have another medication, which is although not the class 1 indication, like the Vericiguat, which has come for a rescue. So, as I said that based on various, the single paradigm HF trial, it was initially adopted as a class 1 therapy for the heart failure with a reduced ejection fraction. And since then, it has shown some great mortality and morbidity benefits so far as the real world evidences are concerned. So the initial concern about the economical impact of this particular medication actually was ruled out by different pharmacoeconomic data, which has shown some significant reduction in the heart failure hospitalization and the cardiovascular mortality. But if you look at the data of the ARNI, since the day the paradigm HF was actually published, so we all know that this particular ARNI actually was the single therapy that actually changed the heart failure outcomes after a very, very long time. So in 2014 September, when it was actually published, then it actually shown some great primary and the secondary outcome benefit, and it actually featured into our guideline. And since then, most of the clinicians involved with the heart failure management or allied things, so they started incorporating this for their heart failure treatment after some initial inertia, but it is slowly catching up. But there is a huge need for this medication so far as the treatment of the heart failure is concerned. So as we discuss right now, the Paraglide HF, which has come with this data, and we had some kind of data from the Paragon in the heart failure with the preserved ejection fraction. But if you look at the heart failure with a reduced ejection fraction, the impact of the ARNI was quite convincing as compared to the other standard of care. So if you look at an Indian perspective, this is a very, very typical problem of an Indian scenario where we tend to have multiple manufacturers trying to compete with the innovator after the patency is actually gone. So that probably because of some kind of economical reason, we try to adopt this kind of policy in India. But unfortunately, what is the problem in this kind of situation is this ARNI or the LCG 696 is not just a simple molecule like a paracetamol or some amoxicillin that can be recreated by anybody. And strangely, if you look at the patent expiry date for the manufacturing know-how, it is still not gone. It is still probably 2026. But in India, we have these generic brands are available. So many of this company, they come and tell that we have our own manufacturing unit, which is probably ethically not possible because of the patency is not yet over so far as the manufacturing is concerned. But if you look at the difference between the generic and the innovator brands of the molecule, so we all know that there is a significant difference between these two groups of medications. So we should know what is the innovator drugs. So these innovator drugs, as the name suggests, they are the first drugs which has been proven in a particular clinical condition and received the initial approval, whether from the European approval or the FDA. And the efficacy, safety, and the quality of this innovator molecule has been tested not only in the phase 3 trial, but 2 trials before that, the phase 1 and the phase 2. So both in experimental subjects and the phase 2 trial that has been proven. So eventually, because of the huge amount of resources utilized for the research, innovation on conceiving a particular entirely new drug, it is going to be definitely expensive because all those costs will be added on to the consumers. So this was typically a presentation regarding what is the basic difference between the innovator and the generic compounds, whether they are pretty much the same. If you look at this particular article, so it is they say the same thing. And if you look at the generic, they simply have no prior data or any kind of quality check as compared to the innovator brand. So that is the basic reality. And if you look at the bioavailability and the pharmacotherapy efficacy, so there will be a certain amount of differences because of the manufacturing process of these two compounds are very different. So we should expect a certain amount of concern regarding when you are dealing with a generic brand versus a innovator brand. Because not only the manufacturing process, because of the certain amount of ingredients that you use for the solvent, for the stabilizer or the expecient, so they can certainly have the capability of changing the whole bioavailability and the bioequivalence of the molecule. And more or less, suppose you look at the DCGI's regulatory requirements, they are quite way absurd, right? So if you are not exactly mimicking the innovator brand, then also they have some kind of relaxation in the both the Cmax, Tmax, AUC. So you can be pretty much 25% within that particular range. And the most important point is whenever we have a generic brand which is going to be cleared by the DCGI, we need to have a single bioavailability testing report. that is not from the diseased individual, it is from the normal individual. So that can be way different from what actually happens in our clinical scenario. So as we all know, this particular molecule is an unique compound. So it is not just a fusion product of a sacubitril and valsartan, but it is a unique co-crystalline structure. And the reason for that, if you look at the data, the previous history of manufacturing this compound, if you look at the valsartan's bioavailability or the dissolution profile alone, as it is universally available as Diovan, if you combine the sacubitril to this Diovan in this particular chemical structure, the utilization of the dissolution of this valsartan remarkably improves. So that means this particular compound, when they are added together in this particular form, the bioavailability and the dissolution improves. So that is what actually makes this product unique. And this innovator Arni, suppose you look at, it is a supramolecular compound, as we discussed that it is a 1-to-1 molar composition. So there is an optimal physical property so far the crystallinity of the compound is concerned, which actually improve the stabilization or the dissolution of the compound and the stability. And definitely it is not a very simplified manufacturing process, as the slide mentions, because it is a manufacturing by the dry compaction method, not by a direct compression method that is used for many of the fixed dose combinations. So these two manufacturing processes are very, very uniquely different. Dry compaction method, it actually utilizes a lesser amount of water, and particularly the two compounds are made into a finely granulated structure and they are fused. So that is how the innovator Arni is manufactured. And that actually gives the unique solubility, stability, and the bioavailability. So that is how this innovator brand is made. If you look at this particular article that we actually, out of curiosity, we did, so we picked up the 16 brands of this compounds that is available, and we tried to test and compare with the various pharmacological characteristics so far as this compound and the innovator compound is concerned. Because clinical outcome data difference, that takes a huge amount of time and requires a huge human resource as well. So we looked at the dissolution profile, the sodium content, melting point, and the PXRD analysis to ensure that whether this compound has the required amount of co-crystallinity or not. So this is the PXRD analysis of the whole compound. If you look at here, so just to tell you about the PXRD analysis, it is basically a X-ray based diffraction technique to actually differentiate between the pharmacological structure of the different components, whether they have an crystallinity of the structure or it is a fixed dose combination. So, and there will be, suppose you pass on the X-rays through this powdered form of this molecule, there is a certain amount of diffraction that happens, and that diffraction actually tells us the uniqueness of the crystallinity or not. If you look at here, there is a huge difference between the diffraction pattern of the innovator as well as the other generic brands. Now, coming to the most important thing, when you take a compound, like it is supposed to have the dissolution which is pharmacologically relevant so that we actually get the pharmacological benefit of the patient. If you look at the dissolution profile of the sacubitril and the valsartan, goes in the innovator as well as the other generic. So if you look at here, this is the dissolution profile of the sacubitril and the valsartan, which is way different from the other dissolution profile. And if you look at the 15, 30, and 45-minute resolution of both the components of this sequential Valsartan, maybe 2 or 3, they may be matching to this particular innovator compound, but majority they had a very, very lower resolution. So that probably will have some kind of suboptimal therapeutic outcome. So that is our belief. But if you look at, suppose we say that these compounds are made by the fixed dose combination, the resolution should be higher than the innovator, causing excessive amount of toxicity. But if you're saying that it is an FDC or a fixed dose combination made by the direct compression method, so it should dilute more. Unlikely. So there must be some other factor which is causing this dissolution, which is suboptimally low. As we know, this particular compound is very sensitive to the sodium content. We need to have an appropriate amount of sodium content to make this this compound relevant pharmacologically. If you have something excess or something low, probably that is not going to have the required amount of effect. Low is still doable, but higher is not accepted. If you look at this data, the sodium content is way higher as compared to the other compound, possibly because of the manufacturing process that has been adopted in manufacturing this. And so far as the melting point, it is a very, very important so far as the stability of the ingested molecular gradient is there. So we need to have a melting point which should be unique, like 133 to 136, that is to be the melting point of the sacubitril. If you are having a melting point of a compound which is lesser than that, that means this particular medication is relatively unstable so far as the melting point is concerned. Similarly, if you look at the valsartan, it is 80 to 95. If you are having the melting point of the valsartan which is lesser than that, so technically it is not going to work. So that is how the pharmacological differences is there. So from a clinical perspective, how they are different. Suppose you have a lesser dissolution profile, it is going to be having a suboptimal pharmacological outcome that we have seen from our data. Suppose you have a higher sodium content, it is again not going to work or not going to be stable. So melting point, again, we have discussed. The co-crystallinity of the PXRD analysis that indicates the co-crystallinity of the compound, which is the core thing that actually has resulted in the adequate dissolution, melting point, and the sodium content. So that is how the PXRD analysis is very relevant so far as this particular unique combination is there. And we all have been using this innovator compound for the last 10 years. I mean, 2016 onwards, 8 years. So we have a decent amount of data that we all have seen. And this future lies in utilization of this compound in various other clinical spectrums, and things are evolving. So far as the ARNI is concerned, be it hypertension, be it coronary artery disease, and acute decompensated heart failure, and so on. So probably time has come that we have to actually rationalize our therapy, what we are choosing, what we are writing. We may not be the pharmacologist or pharmacological scientist, but we should have the basic understanding of what we do and what we write. Thank you.
Thank you, Dr. Rajat, for a very nice and elaborate discussion about the pharmacological aspects, which are not much appreciated by us as a clinicians because we are more interested in treating the patients. But I think underlying thought process is very important to use, especially when the market is open with so many generics flooding the pharma industry. I think we have to be also quality conscious. That is your message. I appreciate it. And I think we have about 15 minutes left for discussion. Now, may I request the panelists to come out with their comments, and then we will take some questions. Dr. Saujatya, and then Vijayant and Mahantesh. Are they available?
Yes, sir.
Good evening. I am Dr. Mahantesh from Bangalore. I think congratulations to both speakers who have presented very nicely and also highlighted what is important right now currently. I think coming to the, this, I think there are two topics. One is the ACC highlights, the other is ARNI. I think regarding ARNI, I think been, getting a lot of information for the last 8 years and being used like, different studies starting from the paradigm heart, then pioneer studies, then transition studies, then we have Paragon, paraglide studies. I think each study have indicated or studied in various clinical settings how they are going to be useful. I think of late, according to this, latest, that is, of course, your the last slide also shows about in the various clinical settings where you have like scope for this molecule in the management of various conditions. I think the burning right now issue is whether to use in a patient with a preserved ejection fraction with a heart failure. I think this paraglide, like we have shown that some of the selected groups of patients where we can definitely use in reducing the event rate and minimizing the mortality morbidity associated with heart failure. And the coming to the other is that the ACC, like I think main issue with regard to this discussion is about inclisiran. I think the ACC upgraded its guide, like a recommendation to the class one indication in case in setting up acute coronary setting also where the people, like do not achieve the target level of the LDL or total cholesterol in spite of having, like statins with, then whether is if they're not able to achieve less than 70 or between to 55 to 60. So they move to the guidelines that is a class one indication. So we can add a non-statin group of medications. So it could be ezetimibe or bempedoic acid or this PCSK9 inhibitors or this the Emceran, that is inclisiran. So they also can be added in this in case like not able to achieve the parameters within a certain time, and also in acute settings also. And of course in I think this like and also long-term effect, like at the end of 3 months, 6 months, and I think they have shown that a beneficial effect in the long term in the minimizing the, this LDL levels consistently for a long time.
Right. Thank you. Thank you. I have one question to Dr. Kamal. You mentioned about usage of ezetimibe and statin, hydrostatin during ACS. Is there a data to support that? Because the data which you have presented 3 years of follow-up is for the chronic stable coronary disease.
Very good question. So the data that has come was for chronic coronary disease. Acute coronary syndrome, still we don't have a data set to support the same. And that's why it continues to be a class 2B indication, not class 2A or class 1. I think it's just the extrapolation that when you don't achieve a goal, then you probably go out and add another. But like starting off somebody on a low dose statin and ezetimibe would not be a good idea. So ACS, you need to go in with a high dose statin first, repeat a lipid profile, you've not achieved a goal. That's endorsed by guidelines to add ezetimibe.
Correct. And one question about the heart failure and preserved ejection fraction, as Mahantesh was mentioning. What is the panel practice in HFpEF regarding usage of ARNI?
So can I go?
Yeah, please. Saujatya.
Yes. So I would answer your question about my opinion first before putting my maybe another point. So at least as far as I am concerned, actually it's about the EF. I take the EF in consideration. So mostly it's in EF less than 60% that I generally try to use ARNI. So that means that HFpEF population, I think it's the 40 to 60% group in which I use ARNI. Above 60%, it's not that I don't use it, but I think not very frequently or not first line. Generally, the go-to agents will be SGLT2 and MRAs. So that is my practice. Can we discuss about the trials So I have a question
Just
for Dr. Kamal Sharma. So, sir, you presented this DAPA Travi trial, and we saw in the videos also that DAPA Travi was a very bombastically presented and with all videos and dancing and all that. So that aside, so one thing about the DAPA trial, the TAVI trial, there were two outcomes. Of course, there was death, and then there was this subjective heart failure hospitalization outcome. So all the SGLT trials. So we are all very enthusiastic about SGLT trials, but this heart failure hospitalization, that was an open label trial. It was done only in Spain, and it was the main success was, again, like all the SGLT trials, was mainly in the heart failure hospitalization, which is a subjective endpoint. So what do you feel about whether this can actually be a practice changing thing? Like in 80-year-old, it was a trial mostly in 80-year-olds. The average age was 80s, I think. So 80-year-olds post TAVI, we can definitely give dapagliflozin. But do you think it's a disease-modifying therapy? It is something that
It's a
modifies
good
the.
question. Fantastic question, so Dr. Sojit. So what you are asking is two aspects. One, doesn't change death, but it that reduces heart failure, hospitalization, or worsening heart failure as it was defined, which included outpatient worsening, functional class worsening, not just hospitalizations. So that's the whole point. But remember, this was the primary endpoint, was a combined endpoint. And when you have similar, as I mentioned in DAPA HF also, the problem was mortality was never reduced. The reason is that when you have a combined endpoint, heart failure hospitalization being an event would happen much earlier than deaths. And that's why the trial will actually reach a statistical endpoint much quicker and would require lesser number of patients to be analyzed. And to look at something like death in an 80-year-old for a therapy to alter probably would require more than 1 lakh patients to end up in showing difference in mortality. We all know that any cause of heart failure, diastolic heart failure with preserved ejection fraction, DAPA or SGLT2 for that matter is going to work. It's a class effect. So I don't see this as a very surprising outcome. We all have been using, even otherwise, in our patients with preserved ejection fraction heart failure, SGLT2 as the first line, which is now the class 1 recommendation. So mortality doesn't go down. Worsening heart failure defined with the clinicians' perspective does definitely goes down. And so does combined endpoint, which is actually driven primarily by worsening heart failure as per definition. But that doesn't mean that we should not be using it. Should be used. And the fear that SGLT2s in elderlies is a risky job, I think that fear has to go out of the head of the cardiologist who actually shy away of using this therapy, especially in our part of the world where there's a lot of humidity in summer. And we think that this therapy will give more of UTIs. Yesterday, I was surprised by one of my fellows saying, I didn't start SGLT2 because this patient has got an indwelling catheter. I mean, how erratic we are, innocuous we can get to not starting SGLT2 because it can cause UTI. I mean, these kind of reasons actually prevent us from giving this therapy. I think this trial just endorses that there's a subgroup of patients which actually should be continued, even if they've undergone a TAVI. Their structural abnormality, the diastolic heart failure, continues to be existing, and in that subgroup, it still works.
Yeah. Any comments from Dr. Vijayant? You're unmute, please. Vijayant.
Please unmute. Dr. Vijayant, sir, please unmute, sir. You're on mute.
Yeah. Okay. Thank you. Thank you, Dr. Pramod, and being the only cardiac surgeon here. So we'll be talking post-revascularization, doing a bypass, and coming to your question of preserved ejection fraction. Yes, see, above 50, I am skeptical in giving, and I'll mostly not be giving. Then, but yes, a lot of patients are having moderate MR. So moderate MR, severe MR, and we believe that after revascularization, these patients would do well, and maybe on T during the surgery, we see some effects that okay, we can overcome without going in for a repair or a replacement, and replacement is more indicated nowadays. So these are the subset of patients, even though with preserved ejection fraction with moderate MRs, so we want to avoid the adverse remodeling, and these are the patients that I'm mostly giving. Otherwise, less than 40 is my choice of giving ARNI in all these patients.
Yeah, I think that's a very good point because ARNI is shown to reduce the mitral regurgitation, and also it decreases the sudden cardiac death requirement for ICDs and all. So
Yes.
absolutely, the indication which you are mentioning really opens up one of the highlighting points about RNA in preserved ejection fraction.
Preserved ejection fraction. Right, sir. Thank you.
And one question to the panelists is, how is the penetration of inclisiran in our therapies to control the lipids?
I guess it's a costly drug, no doubt
Yes.
about that. Yes, and statins do work, but they do work. So we need to have a proper reasoning, when we are giving this drug to us first, and then to the patient. And so, but yes, it is. The trials have shown it is a very favorable drug, and we have to go through the guidelines. And yes, the other point that I will always like to point out that the statins are mostly, at suboptimal levels, the drugs that we are giving. It is never up to the level. So, so this is where, it all matters from doctors to physicians to physicians.
Absolutely right. So are there any other questions? Anything formal wants?
Yes, sir, one question from the panelists. It's LPA testing Dr. Kamal Sharma has presented. So in clinical practice, how you are using it, what's its relevance? So Dr. Rajat Sharma and Dr. Kamal Sharma both can highlight on this.
Yeah, I do it very often in patients presenting with young coronary artery disease. Again, primarily, this has been a practice because we had niacin in good old days to treat this. But post aim high, we know that it doesn't work. It actually causes more SAH, more liver issues, which nullifies the benefits that one may get. There are some molecules in pipeline. We may soon see their outcomes as well. Probably there is one paper I read recently which showed that when lipolytic lowering was propensity match for LDL lowering, there was no outcome benefit. But we all know that lipolytic is a marker for a more aggressive atherosclerotic disease. And that's why you need to be more aggressive in lowering LDL. So I do lipolytic in practically anyone who presents with a rapid or massive atherosclerotic disease, especially in young. And I don't chase it, but I do chase LDLs to a more lower levels as aggressive as I can. And I think that's what this paper actually is highlighting, that lipolytic, when you look, you become more conscious as a treating doctor about your LDL goals. You achieve them more aggressively. You don't know how to modify lipolytic. You don't know whether it works or not, but you're more conscious about being more aggressive in lipid lowering. That's how the strategy is. And that's what the paper also talks about.
Yeah.
Thanks, sir. Last question, sir, to Dr. Rajat Sharma. Sir has presented about the EGCM article, its comparison. So question from the audience, have you seen such differences between innovator and generics in your clinical practice? What's your clinical practice take in your patients? So please, it's for you.
Sir, you're on mute.
Please unmute, sir.
Yeah, that's a very important question. Everybody will start asking after listening to such kind of or going through such kind of article regarding the huge amount of difference that you have between the innovator and the generic compound. And that problem also will keep on asking themselves that I have prescribed an N number of patients regarding heart failure with a preserved reduced ejection fraction with an X brand, and none of them actually has come and actually reported any kind of adverse event. So from my side, what I have done is, so most probably most of the patients, they get an innovator brand of ARNI. So maybe 2 or 3% of the patient who are actually not the right candidate for those ARNI therapy, as per the current recommendation, like the heart failure with the preserved ejection fraction, or maybe some kind of resistant hypertension that I prescribe offline. And some of this heart failure with a reduced ejection fraction, because of some reason, because of administrative reason, like most of our patients in Punjab are from the army background or from the government retired employees program. So they eventually go back to their dispensary and they don't get this innovator ARNI, right? So these are the population of patients where you have an opportunity to actually identify the clinical or the investigational, the biomarker differences so far as the innovator and the this. So clinically, I've seen some kind of decline in some of the patients, not all, not in the majority of the patients. But if I look at the biomarker analysis of this patient, they actually are hugely different on follow-up. So there may meaning that innovator brand and the generic population, they will have a significant difference so far as the biomarkers difference. And if you acutely see these patients very, very closely, there will be some kind of functional decline that I have seen. So far as the hypertension populations, so I was actually inclined to give this generic brand so far as the hypertension treatment is concerned, like 200 milligram, and anticipating that they are going to do wonder. But unfortunately, that I've seen that many of these patients, they are better controlled with a telmisartan monotherapy or twice daily dose rather than a 200 milligram of this medication in some of the patients, not all. So that actually give me a speculation regarding whether I'm dealing with the low solubility or a low bioequivalence of this generic compound, which may be responsible for the suboptimal antihypertensive effect in our population. So these are the few not very relevant, but clinical assessment that I have seen in my practice.
I think a follow-up study of yours comparing few brands using biomarkers may be very valuable.
That will be very good. Yeah.
Yeah.
Yeah. So we covered almost all questions. Now I request Dr. Pramod Kumar sir to give the concluding remarks for the meeting.
Yeah, thank you so much, Dr. Kamal Sharma and Dr. Rajat, for excellent disposition of both the topics which you have dealt, and also active participation from our panelists, Saujatya, Dr. Vijayant, the only cardiac surgeon in the group, and Mahantesh, with their wonderful insights about the topics. Actually, the topics are too many. Dr. Kamal should be complimented for covering blazing speed, all the 10 trials. And he has done justice to all of them so that we really take home the messages. And Dr. Rajat also has given very wonderful ideas about his experience, practically how this pharmacological trial helped him to also translate into clinical practice. So these are really good take-home points on this evening. Thank you very much, all the speakers and panelists. Komal for moderating and guiding us through this. And JB Pharma, thank you very much. Hope to see you again on the similar platforms to learn more.
Thanks a lot, sir. On behalf of JB Pharma, I would like to thank all the expert panelists, the moderators, sir, Dr. Pramod Kumar, sir, and both the speakers. Thanks for your valuable time, and thanks all the audience for this wonderful evening meet. Thank you, sir. Thanks a lot. We're ending the meet. Bye, sir.
Thank you. Good night.
Thanks a lot. Good night.
Yeah, thank you so much, everyone. So from here, I'm ending this meeting. Thank you.